Hello all, welcome back to my channel. Today we are discussing the MRCP Part 1 sample questions, which is there in the RCP website, the official website. So I decided I'll make a detailed explanation so that it can be useful for the last minute revision for whoever is preparing for exams in the upcoming slots. So all the best for your exam in advance, and let's get started. So here's question 1. A 65-year-old woman presented with a 12-hour history of sudden onset gait unsteadiness, vomiting and headache, followed by increasing drowsiness. What is the most likely diagnosis? So as I had sat for the August exam, what I realized that they have more of straightforward and some fact-based questions. They do have clinical questions as well, but the question is not that lengthy as opposed to what we see in past test or any study material. It's almost a straightforward question. So here the key in answering a question is to identify the keywords, identify what they are really trying to ask you and what is the hint in the question. So when you read a question, before you come to a diagnosis, always look at the age of the patient, look at the duration of presentation, whether it's acute or a chronic course of illness, and what the presentation is like. So here is a 65-year-old woman, and also gender matters because in some there is a sex predilection towards female or male, like that. So everything has to be kept in mind before you commit on an answer. So here it's a 65-year-old woman presenting with a 12-hour history of sudden onset gait unsteadiness, vomiting and headache. So it's a acute onset and sudden onset gait unsteadiness, vomiting and headache. Gait unsteadiness can be a cerebellar sign, and again it's a 12-hour history, which is a short history, so it can be a vascular phenomenon followed by increasing drowsiness. So it can be an intracerebral hemorrhage. So the options are acute cerebellar hemorrhage, acute subdural hemorrhage, frontal subdural empyema, herpes simplex encephalitis, and pituitary apoplexy. Once you commit on an answer, always make sure that the other options are wrong. So here when you see it's a sudden onset and a short history of a vascular phenomenon which is presenting with gait unsteadiness, you almost commit to the answer of acute cerebellar hemorrhage. So you have to see why the others are wrong. Acute subdural hemorrhage, how do they present? They can present with a mass effect. Subdural hemorrhage can initially progress, then they have to do a mass midline shift. Only then will they kind of worsen. Again, sudden onset gait unsteadiness is more likely to be cerebellar than subdural. Frontal subdural empyema, there can be the frontal signs like disinhibition, personality changes, which is not there in the question. Herpes simplex encephalitis more likely there is encephalitic picture where there is an altered consciousness, which is not the initial presentation. Pituitary apoplexy also not the likely cause here. So the answer here is acute cerebellar hemorrhage. So we'll see a bit about intracerebral hemorrhage. So intracerebral hemorrhage, the most common sites are putamen, thalamus, pons, and cerebellum. Just like in our question, it's a cerebellar bleed. Again, the bleeds can be extradural or epidural. It can be subdural. So we have three layers of the meninges, which is the dura mater, which is the outermost layer. We have the arachnoid matter and pia mater, which is close contact with the brain matter or the brain parenchyma. So anything outside the dura is called epidural, which classically has a lucid interval. So there is a trauma, a sudden hit, or sometimes they fell on the ground, hitting the head. There is a period of loss of consciousness followed by a lucid interval where the patient is completely okay. They regain the consciousness and they act like nothing has happened. Then they have a sudden deterioration, which is classical of epidural hemorrhage. So extradural hematoma or epidural hematoma, think of lucid interval. Then you have subdural hematoma, which is uh, under the dura, inside the dura mater, which can present with the midline shift and the presentation based on the lobe that they have affected. Then you have subarachnoid hemorrhage, which is inside the uh, uh, subarachnoid space or in the subarachnoid space, which is between the arachnoid and pia, not again in the brain parenchyma. Then you have intracerebral hemorrhage, which is inside the brain parenchyma, which we have told the four likely sites are putamen, thalamus, pons, and cerebellum. Among that, pons has classical features of your pinpoint pupil hyperpyrexia, which is classical of pontine hemorrhage. Again, intracerebral hemorrhage can be primary or secondary. Primary can be due to cerebral amyloid angiopathy, which is a vascular abnormality, or hypertensive vasculopathy, which can be common cause in elderly. And secondary, like due to any other AV malformations or a tumor or a cavernous malformation or infective endocarditis, like septic emboli. And the treatment strategy for primary is first you have to exclude secondary hemorrhage like any mass or a tumor or AV malformation, and then you have to control the blood pressure, which is the likely cause for primary intracerebral hemorrhage. Reduce or eliminate anticoagulant or antiplatelet therapy. And for secondary, you have to identify the treat underlying mechanism. And conventional angiogram and vascular malformation is suspected, or you can do transesophageal echocardiography when you suspect endocarditis. So it is basically to treat the underlying cause. So that is a bit in detail about the various intracranial bleed and intracerebral bleed. Extradural hematoma, just like what I told, the classical is your lucid interval where the patient regains consciousness after the initial loss of consciousness and then they deteriorate again. That in between period is called lucid interval, and that's classical of extradural hemorrhage. SH, they usually talk about thunderclap headache or worst headache of life. Usually this is the keyword, worst headache. So SH has the worst headache. So that is classical of SH. So you have EDH, SH, SDH, and intracerebral bleed. Coming to next question, a post-marketing observational study of a new drug was conducted on 5,000 patients following clinical trials. What best describes the data generated from this type of study? So this is a post-marketing observational study or a post-marketing surveillance. So that is when the drug is already been marketed, it's been circulated, it's been used on the patients, and then they are doing a observational study. So what are you actually trying to characterize? It's the adverse effects. So it is a phase 4 trial, which is the profile of adverse effects. Other options are comparative efficacy, cost benefit, cost effectiveness, potency, and profile of adverse effects. The answer is profile of adverse effects. We'll see what are the phases of clinical trial. In total, there are 4 phases for a clinical trial. Phase 1 is when young healthy people, it's not on the patients, it's a very initial stage of the trial where after the animal trial they are being um, uh, ready for use in human population. Initially they use in healthy people, about 50 people, and they try to test the possible harm, the side effects, and the dosage. Phase 2 is when they are being used in the diseased population. So you identify the effectiveness of the treatment, again the side effects, and usually against a placebo, so that you can compare the efficacy. Phase 3 is when even a larger group, up to 1,000s, they are being tested. So you are identifying whether the treatment is effective, again in patients and over long periods and over many different countries. Again, often tested against existing treatments. Now the treatment, when they are deemed safe or effective, they're licensed for marketing and distribution among patients and different countries. Then happens a phase 4 trial where you are identifying the profile of adverse effects on a large scale. Okay, so here in the question it was a large scale post-marketing surveillance. So that is a phase 4 trial where it is used to identify the profile of adverse effects of the drug. Third question, a 79-year-old woman was admitted for elective hip replacement surgery. On examination, she was pale. There was 2 centimeters splenomegaly and there were small discrete axillary lymph nodes. So the key in this question is she was pale, she was anemic, there is splenomegaly and there is lymph nodes, and she is 79-year-old. So in these kinds of questions, when the questions from hematology comes, there is splenomegaly, lymph node, she is pale, anemic. You see the white cell count, which is 34,500, which is large. You have to identify also the age. So in a 79 elderly with splenomegaly, anemic, this high white cell count and lymph node, you think of what is the most likely diagnosis? So it is one of the hematological malignancies. Is it AML, CLL, CML, myelodysplasia, or myelofibrosis? So it is CLL because this is the commonest hematological malignancy in adults. Also in CML, you also get thrombocytosis, which is not the case here. Here platelets were normal. So CLL is the commonest malignancy. Now I'll give the keywords in the other hematological malignancy. For example, in AML, they talk about ORODs. And AML M3 is the most commonest form, which is APML. AML has further subclassification, M1, M2, M3, like until M7. So in AML, microscopically, you can see ORODs. That is one key for AML. Then the usual presentation is APML, acute promyelocytic leukemia, which is due to the translocation 15-17, that is PML-RARA. PML-RARA, there is fusion of 2 genes and 2 proteins in the chromosome 15 and chromosome 17, and the treatment of that is unlike other hematological malignancies, the treatment here is all trans-retinoic acid. So even in the fusion, you can think about retinoic acid. RARA stands for retinoic acid. So it's a PML-RARA fusion translocation 15-17. APML is the most common form, which is AML M3, and it has a good prognosis. And the treatment is all trans-retinoic acid. All this thing you have to know because there were so many questions regarding this. And the usual presentation of APML is like DIC. So when you are given a presentation where the patient is in disseminated intravascular coagulation, where APTT is high, and so there is low platelet, and the patient is in a consumptive coagulopathy stage, which is the DIC. If you see in the options both DIC and APML, think of APML because the common cause of DIC, when the picture is more likely to be hematological malignancy, you have to think of APML because APML usually presents with DIC. So that is AML M3, good prognosis, translocation 15-17, PML-RARA gene fusion, and the treatment is all trans-retinoic acid. Then comes ALL, which is more common in children. CML, there could be thrombocytosis, and it is translocation 922, a classical Philadelphia chromosome or BCR-ABL fusion protein. And this BCR-ABL in CML, it is classic, but when it comes in other malignancies like CLL, this Philadelphia chromosome indicates poor prognosis. Not in CML, In CML, it is usually the classic chromosome abnormality. But in others, like when it comes the same Philadelphia chromosome, if it comes in CLL, it indicates bad prognosis. Now, CLL is the most common hematological malignancy in adult. The single drug treatment for CLL is chlorambucil. Again, this has come in the exam previously. This is chlorambucil. So here the answer is CLL. Next question, a 17-year-old boy presented with a non-blanching rash over his legs, a swollen knee and painless visible hematuria. Urine analysis showed blood 3+, protein 1+. So the age is 17, there is non-blanching rash, a swollen knee and painless visible hematuria. So there is rash, there is hematuria and swollen knee. And the creatinine is high, urine culture is negative, ultrasound scan of kidneys are normal. And there is hematuria and proteinuria. What glomerular abnormality is most likely to be present? So there is rash, blanching rash and non-blanching rash and hematuria as well as knee pain. Answers are focal segmental sclerosis, food process effacement, linear deposition of IgG, mesangial deposition of IgA, thickening of basement membrane. So this is classical of IgA nephropathy where there is mesangial deposition of IgA. So more likely like an HSP-like presentation where there is rash or purpura. You have hematuria, proteinuria. Okay. FSGS, not like this. Food process effacement, there is only microscopic, electron microscopic changes of food process. There are no much changes. Linear deposition of IgG is classical of the Goodpasture syndrome, where there is also pulmonary involvement, which is not mentioned in the question. Thickening of basement membrane is classical of membranous, which can happen when there is an underlying malignancy and all. So here it is classical of mesangial deposition of Ig or IgA nephropathy. So that is HSP, rash, arthritis and acute glomerulonephritis. When there is a triad of rash, arthritis and acute glomerulonephritis, think of HSP where there is mesangial deposition of IgA. Okay, so there is a slight difference between IgA nephropathy as such and HSP, but in HSP also there is mesangial deposition of IgA. This question is a 25-year-old woman attended the genitourinary medicine clinic for a sexual health screen. She was asymptomatic and had been previously well. Anti-hepatitis B core IgG antibody positive, anti-hepatitis B core IgM antibody negative, anti-hepatitis B surface antibody positive, hepatitis B surface antigen negative. I have to give you an introduction into this hepatitis antibody and antigen, because this can come in very twisted manner, come in a different permutation combination. You have to know what comes when. Once you understand the core idea, it becomes a piece of cake. Otherwise, it's a real pain to identify what is happening here. So you have to understand there is initially hepatitis B surface antigen, and that comes both with your vaccine and with your active infection. The antigen I'm talking about. So you have to understand there is antigen, there is antibody. So once the antigen comes to your body produces antibodies against that antigen. So you have your surface antigen, you have your core antigen, and you have E antigen. Now think surface antigen is the one that is coming initially. With your infection, it's also present in the vaccine. But core antigen comes only with infection. It doesn't come with your vaccine, because vaccine has only surface antigen. So when you're vaccinated, your body produces antibody against that surface antigen, because you are being exposed to that new antigen, which is surface antigen. So your body produces hepatitis B surface antibody, not antigen, antibody. Your body produces antibody. So once you're vaccinated, you can have this anti-hepatitis B surface antibody. So that comes with vaccination. Understand core antibody. never comes with vaccination, it comes only with infection. So if there is a past infection, you would have already produced antibody against that, and that will give you anti-hepatitis B core antibody. Now IgM, IgG, you know, IgM is the one that is coming first, IgG is coming on later. So when there is IgM, this is the initial stage. IgG, there is a long gone story, it's a past infection. Okay. Now coming up, E antigen. E antigen indicates active infection, that is the patient has higher infectivity, higher chance of spreading to other person. Again, against E also you can have antibodies. Okay, so there is your surface antigen, core antigen, and E antigen, and you have antibodies against these. You have IgM, IgG. IgM is the acute thing, IgG is chronic thing. Surface antigen comes with both vaccination and infection. Core antigen comes only with infection. E antigen indicates infectivity. Okay. We'll see the combination and permutation of this in a table. Here, what is happening? There is anti-hepatitis B core antibody, which is IgG. IgG, I told you, it's a chronic case. It's a long gone story. It's not an acute thing. So there is core. Core means the person has previously been infected, not vaccinated. The person has previously been infected because core is not there in the vaccine. So core antibody, the body has produced antibody against a core antigen. That means the person has previously been infected. She has been cured of the infection because there is antibody, and that is also IgG. So it's a long gone story. So that means it's a past infection. Now core IgM antibody, it's negative. Anti-hepatitis B surface antibody is positive. So that also comes with infection. That antibody is also there, which means she had a past infection which is completely cleared now, right now, because there is no hepatitis B surface antigen. Sometimes what can happen, you have both antibodies and surface antigen. That means you are a carrier. You can like spread to some other, but if you don't have hepatitis E antigen, that means you don't have that much infectivity, but you still can be a carrier. Here the surface antigen is negative, so that means what is the most likely diagnosis? Is it acute hepatitis B? No. In acute hepatitis B, you could have surface antigen or maybe surface antibody also, but core, again, you have IgM antibody, not IgG. Chronic hepatitis B, no, you don't have surface antigen now, so it's not chronic. It's a gone infection which is completely cured. False positive, no. Previous infection with hepatitis B, yes. Previous vaccination, no. Why not? Because vaccination does not contain your core antigen or antibody. So this is the serological response to HBV infection. So this is stage of infection. Here we are decoding what happens with the surface antigen, what happens with your surface antibody, what happens with your E antigen, E antibody, and core antibody. So incubation stage, so when the patient is infected, but they have not started to manifest. So then you can have your surface antibody. They have not produced you can have surface antigen, but the body has not started producing its immune mechanism. It has not started producing antibodies against HBS. So you can have hepatitis B surface antigen, and E antigen can be plus or minus depending on the degree of infectivity or spread that the patient potentially has. Acute hepatitis B, you can have surface antigen, E antigen, and core antibody. Okay. So core antigen is also being exposed to the immune system in active infection. So the body tries to produce antibodies against that. Hepatitis B negative acute hepatitis B. So surface antigen can be negative in some acute infection, where the core antibody is positive. So core always comes with infection, not with vaccine. So it has to be hepatitis B surface antigen negative acute hepatitis B. What happens with chronic hepatitis B? There is surface antigen, there is E antibody, and core antibody. Okay. Convalescent hepatitis B infection. So the patient has been infected. Now they are in a convalescent stage. There you have not hepatitis B surface antigen because that indicates active infection. They have antibody instead. They can have anti-hepatitis B E antigen and anti-hepatitis B core. Now with vaccine, you don't have the core, you only have the surface antigen. So the body produces antibody against surface. I hope this is clear. Just remember that with vaccination never comes core. Core only comes with infection. E indicates the spread or infectivity, the degree of infectivity. And surface comes with both infection and vaccination. IgG indicates a chronic or a past infection. IgM indicates an active infection. Okay, so this is all. Just try to understand the core concept. Then don't try to memorize the combination. It becomes a real pain. So just try to understand the core concepts and then the combination becomes easier. Next question, a 45-year-old woman presents with right flank pain. She had a 4-year history of hypertension, progressive cognitive impairment. On examination, she had livedo reticularis and tenderness in the right flank. Her BP was 185 over 105. Urine analysis showed blood 3 plus, protein 1 plus. Investigation showing HB 12.9, white cell count 8,700. Platelet count is 83,000. Serum creatinine is 106. So she's a 45-year-old woman coming with right flank pain. And there is history of hypertension, cognitive impairment. She had livedo reticularis, tenderness in right flank. One BP is high. Urine analysis is showing both blood and protein, and there is low platelet. So when you hear livedo reticularis, tenderness in right flank, think of some venous thrombotic phenomenon. Okay, so there is some thrombotic phenomenon happening here, and there is low platelet, and there is high BP, and there is kidney involvement. Is there anything striking? We'll look at the options now. What antibody test is most likely to be positive? Is it ANCA? ANCA comes with CNCA or PNCA. CNCA is your granulomatosis with polyangiitis. PNCA is your Churg-Strauss or eosinophilic granulomatosis with polyangiitis and microscopic polyangiitis. All of this comes with a combination of your respiratory and renal manifestations. Your granulomatosis with polyangiitis has sinusitis and pulmonary hemorrhage and renal hematuria manifestation. Your Churg-Strauss has eosinophilia and things like that. So that is not the case here. Here we have a venous thrombotic phenomenon with a low platelet and a renal manifestation. Anticardiolipin, which is suggestive of APLA. APLA can be a case, right? Because APLA has venous thrombosis, APLA has low platelet, and APLA can have renal manifestation. Anticentromere is they're seen in limited cutaneous systemic sclerosis, which is not the presentation here. Okay, that's a rheumatological manifestation. Anti-GBM again have pulmonary manifestation, not given in the question. Antimitochondrial antibody comes with your primary biliary cirrhosis, which is not the presentation here. So it could be anticardiolipin. So this is at APLA because low in pain, livedo reticularis, cognitive impairment all indicate thrombosis, which can be suggestive of APLA syndrome. So you have to look at the question as a whole in a holistic manner. You can't pick one and comment on the answer. If you just look at the hematuria part, even your ANCA can come and other options, you'll have a doubt. But think of all the presentation that the patient is having and come to a combined diagnosis or a conclusion. Always also exclude other options. Okay, so here it is anticardiolipin suggestive of APLA. What are the other antibodies in APLA? Do you remember? Anticardiolipin, anti-beta 2 microglobulin, Just look at that, okay? Next question. A 37-year-old woman presented the history of intermittent lightheadedness. Examination was normal. Investigation showed ECG, normal, 24-hour ambulatory ECG, atrial and ventricular premature beats, nocturnal bradycardia, and Mobitz type 1 AV block and supraventricular tachycardia. Which abnormality on 24-hour ambulatory ECG is clinically most important? They are asking what is the abnormality seen in the 24-hour ambulatory ECG, which can explain the symptom of the patient. That is intermittent lightheadedness. So they had atrial and ventricular premature beat, nocturnal bradycardia. Nocturnal bradycardia cannot present with intermittent lightheadedness, right? Mobitz type 1? No. So what is more significant is supraventricular tachycardia. So that is the answer, supraventricular tachycardia, which can explain the intermittent lightheadedness. Next question, a 28-year-old man presented with 1 month history of weight loss, abdominal distension, flatulence, and foul-smelling diarrhea following a visit to India. So here, there's some keys in the question. So there is weight loss, there is abdominal distension, flatulence, and there is diarrhea. And it's 1 month history. So it's a bit chronic. And after visit to India. So there is visit to one of endemic countries. We'll see what disease it is. But when there's a kind of history of travel or visit to any country, think of its endemicity or certain diseases pertaining to that country. Here there is weight loss and smelling diarrhea. If it could be infective, it could be giardia. If it's not infective, it could be celiac disease. Or think of the differentials in your head. There is no mention of blood in stool, so don't think of Crohn's and ulcerative and all. And there is 1 month history of weight loss and diarrhea, so you can think of giardia. Anti-TTG, which is classical of celiac, is negative. Stool culture microscopy is negative. Again, giardia can have negative stool culture. It cannot always come with a positive stool culture. So the likely diagnosis here is giardia, which is a classical presentation of long-standing diarrhea and weight loss. Okay. Sometimes you can have trophozoites in stool, which they mentioned. Here they didn't mention that, and the culture is also negative, which can happen in giardia. Question 9. A 30-year-old woman presented with a 6 month history of tremor and difficulty in speaking. On examination, she was found to have increased muscle tone in all 4 limbs, bradykinesia, and 4 cm hepatomegaly. What lab finding would support a diagnosis of Wilson disease? So you have to actually care about what is given in the final sentence of the question. So they are asking about Wilson disease, so you don't need to spend time in finding the diagnosis, because the diagnosis is already given. So there is tremor, difficulty in speaking, increased muscle tone and bradykinesia with 4 cm hepatomegaly, and they are giving a diagnosis of Wilson's disease. Okay, with the neurological impairment. They are asking what is the finding that best support diagnosis of Wilson disease, or a confirmatory test for identifying Wilson. Options are increased. So Wilson is when there is increase in copper and there is copper deposition in the body, and there is decrease in ceruloplasmin because ceruloplasmin will be used up. Answers are increased incorporation of radioactive copper into ceruloplasmin. Option B, low hepatic copper count. No, there will be higher copper count in the if you take a liver biopsy. Low serum ceruloplasmin concentration. That could be an answer because all of the ceruloplasmin will be used up, because ceruloplasmin is the one binding to copper. Low serum free copper concentration, no. Copper is very high in the body. Low urinary copper concentration, no. Since copper is high, urinary copper will also be high. So the answer is low serum ceruloplasmin concentration. Okay, so Wilson disease can affect many organs in the body. There can be renal involvement with proximal renal tubular dysfunction, that is type 2 RTA. There can be liver involvement with hepatomegaly, jaundice, acute hepatitis. There can be fulminant hepatic failure or progressing into cirrhosis with portal hypertension and bleeding varices. Bone involvement with arthritis and rickets. There can be hemolysis. Central nervous system involvement where there is deterioration, there is behavioral changes, incoordination, their handwriting deteriorates, there is resting as well as intention tremor based on where it is affecting. Dystonia, dysarthria, excessive salivation, mask-like facies and dysphagia. Eye involvement, this is also one of the favorite question, usually repeated case of leisure ring. Okay, in the decimate membrane there is deposition of copper in the eye, which is called in the cornea. The cornea has different layers, right? So there is in the decimate membrane there is deposition of copper, which is called the case of leisure ring. There can be cardiac involvement also, cardiomyopathy, and the inheritance pattern is autosomal recessive. Treatment of choice is D-penicillamine. Okay, a chelating agent for copper. That's called the D-penicillamine. So there is low serum ceruloplasmin concentration in Wilson disease. Next question, what dietary substance is broken down into glucose and galactose by the action of intestinal enzyme? So you just have to know what are the constituents of different sugars. So here they are asking about glucose and galactose. That is a straightforward question. It is lactose. Fructose is another simple sugar, just like your glucose. Maltose is glucose plus glucose. Mannose is not the thing. Sucrose is also a complex starch. So it is lactose, which is glucose plus galactose. Very straightforward and a fact-based question. Next question, a 16-year-old girl presented with a non-scaly discrete areas of hair loss on scalp. She had a history of atopic eczema and a number of depigmented areas on her hands and around her eyes. What is the most likely diagnosis? So it is non-scaly, non-scarring alopecia, also a history of atopic. So it is alopecia areata. It can have an autoimmune association as well. So that is non-scarring alopecia. That is alopecia areata. Other options like trichotillomania means the psychiatric disorder where the patient itself will pluck their hairs. There is no autoimmune association. There can be psychiatric illness related, and there are also small hairs that is growing because they cannot pluck that hair, and there is not like a patchy area. It can be different patches. Hypothyroidism can also be associated with this hair loss, mydriasis, and the loss of hair, earbrow, eyebrow hair, and everything. But again, hypothyroidism will have its own features along with hair loss or mydriasis, which is loss of eyebrow. Your lupus can have alopecia, but that is a scarring alopecia. So those were the other options. So the answer is alopecia areata, which is non-scarring alopecia. Next question, a 72-year-old man presented following an episode of collapse. There had been 2 similar episodes recently, each lasting about 1 minute. So there is recurrent history of collapse. He had an anterior MI 4 years previously. On examination, he was oriented and symptom-free with a regular pulse of 80 beats per minute, BP is 140/80, and average speed was displaced to the left. So there is some amount of maybe cardiomegaly. There was an apical systolic murmur. There were no signs of trauma. So there is recurrent collapse or syncopal episodes. He had passed MI. He is having an apex speed which is displaced to left, and he is having an apical systolic murmur. No signs of trauma. ECG showing sinus rhythm with anterior Q waves, anterior ST elevation without reciprocal depression. So he had anterior MI, so anterior Q waves could be a thing from the MI, previous MI. He is having ST elevation without reciprocal depression. So what could be the possibility? Acute anterior MI is not having ST elevation with reciprocal depression, so it's not MI. cerebral embolism, epilepsy, pulmonary embolism, ventricular tachycardia. So in this case, the answer is ventricular tachycardia because that can result in a picture like this where there is having collapse, um, and there is a there is an LV dysfunction or an LV dilatation where big spit is also dilated. There is also a systolic murmur. Okay, so it could be weak. Next question is a 26-year-old woman presented with unequal pupils. So this pupil related question is also another important area. So here anisocoria, unequal pupil means anisocoria. On examination, the right pupil was larger than the left. So the right pupil which they are talking about, that is the deceased pupil. If the deceased pupil is larger than the normal pupil, we have a certain differential. If the deceased pupil is smaller than the normal, we have certain differential. If the deceased pupil is larger than the normal, we have differentials like adistonic pupil. If the deceased pupil is smaller or there is meiosis, we have differentials like Argyll-Robertson pupil, which is seen in syphilis. We have Horner syndrome, which can be meiosis and hydrosis, and in ophthalmos, ptosis, and everything. That is the defect with the sympathetic pathway. And third, cranial nerve palsy. Cranial nerve is helping the eyes to contract, or it is the nerve which is required for the constrictor pupillae to act. So if there is third nerve palsy, the constrictor pupillae cannot act and there can be dilated pupil. So dilated pupil, you have your adistonic pupil and third nerve palsy. Constricted pupil, you have your Argyll-Robertson pupil and Horner syndrome. You have to correlate with other signs and symptoms to understand which is which. Okay. So this is the deceased pupil is larger than the normal, and it is not reacting to light directly or consensually. On accommodation, right pupil reacted very slowly, but eventually became smaller than the left pupil. So there is no reaction with direct or consensual reflex. See, the light reflex is important in the fact in a way that how it is acting. For light reflex, what is light reflex? When a light is shown to an eye, the eye constricts, the pupil constricts. Not only that pupil constricts, the other pupil also constricts. When the light is shown to right eye, if the right eye is constricting, that's called a direct light reflex. And if the left eye is constricting, when the light is shown to right eye, that's called a consensual light reflex. For light reflex, you have two cranial nerves involved. The afferent is carried by the optic nerve, that is second nerve, and the efferent, that is the constrictor pupil action, is carried out by third nerve. Both of these have to be intact for the light reflex to act. So if there is a afferent pupillary defect, where there is defect with the optic nerve, but the third nerve is okay, you will have a swinging light reflex. That is called relative afferent pupillary defect, or RAPD. RAPD is when there is defect with the afferent pathway, that is your second nerve or optic nerve. So when the optic nerve is not taking the information from the eye, that will not constrict by the direct reflex. But for consensual reflex, like for example, if the right optic nerve is damaged, it cannot take up information to the brain, and that I cannot constrict by direct reflex. But right eye, if it has a RAPD or a afferent pupillary defect or an optic nerve damage, it can constrict by consensual reflex, meaning that when the light is shown to the left eye, which is the normal eye, the information will be carried out by the optic nerve of the left eye, which is intact, and the information will be passed through the third nerve of the right eye, which is also intact. So that consensual reflex will be okay. Direct reflex will be not okay. That is called RAPD, and that is detected by the swinging light reflex. So you are swinging light from one eye to the other. For example, if you have a right RAPD, when you are showing the light to right eye, it will not constrict, but when you are showing the light to the left eye, it will constrict. So when you are swinging the light in between the eyes, it will seem as if the pupil is dilating in response to light, because when you are showing to the left eye, the right eye would have been constricted by concentric reflex. When you're showing the light back to the right eye, it will not have an intact direct light reflex, so that it will relax from the concentric reflex which we had done while showing the light to the left eye. So that relaxation will seem like it is showing a dilatation in response to light. That is called RAPD, which is not the case here. I just wanted to enlighten what was RAPD. Here, there is it is not reacting to light directly or consensually. Both are damaged. Okay, no direct reflex, no consensual reflex, and only to one eye. On accommodation, right pupil reacted very slowly, but eventually became smaller than the left pupil. So this is the adistonic pupil. So there is a tonicity. Okay, the pupil is uh, this thing that's called adistonic pupil. The pupil is large, regular, and usually unilateral. Reaction to light is severely reduced and slowed or even absent. Near reaction, that is called the accommodation reflex. Although very slow, it is present. Slow accommodation can cause blurred vision. Deep tendon reflexes are also decreased. What happens in cranial nerve palsy, third nerve palsy? Third nerve palsy also there is dilated pupil, because constrictor pupilla is supplied by the third nerve. The dilated pupil is fixed to light and near effort. Again, there can be ptosis of the upper lid, because that is also supplied by the third nerve. And lateral deviation of eye is almost always present, because the extraocular muscles, except LR, we call it LR6SO4, right? That was a code. We say LR6SO4. That means lateral rectus is supplied by the sixth nerve, and superior oblique is supplied by the fourth nerve. Okay, sixth nerve is abducens, fourth nerve is trochlear. So except these two extraocular muscle, all of others are supplied by the oculomotor nerve. So the eye will be down and out, because that is the only action that is remaining. All other actions are paralyzed. So that will be there in third nerve palsy. The eye will be dilated, the light and near effort all will be fixed, and there will be ptosis, and eye will be down and out. Then there comes Horner syndrome, which is the defect with your sympathetic pathway. The eye is small than the normal eye. It reacts briskly to light and near effort, because there's no damage with either your second nerve or your third nerve. So the reflexes are okay. There will be ptosis, anhidrosis, and ophthalmos, and in congenital Horners there can be the involved iris is lighter in color than its fellow, which is called heterochromia. That is, difference in color between the iris is called heterochromia. Then you can have your small irregular pupil that can accommodate but do not react to light. That's called Argyll-Robertson pupil, which is seen in tertiary syphilis. So this Argyll-Robertson, there is a mnemonic to remember it. Argyll-Robertson pupil, ARP. So forward, when you go ARP, you call it accommodation reflex present, ARP. PRA, when you go from back to the front, PRA means pupillary reflex absent. That is how you remember Argyll-Robertson. It is small than its fellow eye, than the normal fellow eye, and it can accommodate, but it don't react to light. Okay, so that was about our pupillary defects. Now next question. 45-year-old man had recurrent Nephrolithiasis. Renal function test and serum calcium test measurements were normal. Here are certain measurements. 24-hour urinary calcium 8.8, which is a bit high. So there is increased calcium excretion. 24-hour urinary urate is 3, less than 3.6 normal. Urinary oxalate 0.2 normal. Urinary citrate 0.2, which is reduced. What is the most useful therapy to reduce joint formation? So when the citrate is low, you have to give potassium citrate. You give citralca, right? So that will help because that can reduce the calcium excretion through urine. That is the answer, potassium citrate. Others are not going to help here because there is increased calcium excretion through urine. You have to give something that can chelate or bind to it. Here, if citrate is also low, so it is going to help. Okay, that is potassium citrate. Next question, a 38-year-old woman required extraction of her wisdom tooth. She gave a history of hemorrhage after dental extraction 10 years previously when she had required suturing. There had been no history of excessive bleeding before this. What is the most likely diagnosis? So, usually there happens questions like this where there is an increased tendency to bleed, and the commonest cause of that without major other abnormalities or no other history is von Willebrand. Okay, and in the options, factor 5 leiden, factor 9 deficiency. Factor 9 deficiency is your hemophilia B, which can happen with like hemarthrosis. There could be other manifestations, and it will not happen suddenly in a patient, years later. It can present earlier itself. Factor 12 deficiency. No, primary antiphospholipid, that is again a prothrombotic phenomenon, not a bleeding manifestation. Factor 5 leading mutation is also a bleeding manifestation. Which is actually basically your protein C resistance. So there is protein C adequately, but there is resistance to its action. That is why you have again a prothrombotic phenomenon. But von Willebrand is the most common coming with bleeding manifestation, which is not so severe. And usually they ask about the management of von Willebrand. Suppose they are coming for procedures like dental extraction and all, you have to give them desmopressin. That is one of the favorite questions. Desmopressin, what they do is they release the stored von Willebrand factor as well as factor 8. So that is desmopressin. That is the management. If it is more severe, you have to give other prothrombin complex concentrate, or you have to give FFP if there is severe bleeding. But otherwise, prophylactically to reduce bleeding, you can give desmopressin. It releases stored von Willebrand factor as well as factor 8. Okay, von Willebrand factor, what they're doing, it is there in the 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 clotting pathway, right? It has to the exposed collagen attaches to the platelet by the von Willebrand factor, so it has to be there for the clotting to occur. If there is a deficiency in that, bleeding will manifest. Next question, a 30-year-old man presented with increasing breathlessness and wheeze. He smoked 5 cigarettes per day. Investigation is showing alpha-1 antitrypsin 0.12, FEV1 0.85, FVC 4.75, transfer factor for CO is 4.1. So transfer factor is reduced, FVC is normal, FEV1 is reduced. So and alpha-1 antitrypsin is low. Which protease inhibitor phenotype is most likely to be present? The options are MM, MZ, SS, SZ, and ZZ. So this is about the alpha-1 antitrypsin deficiency. You don't need not go and bother about the lab values. Lab value again, FEV1 is reduced because it's an obstructive phenomenon. Alpha-1 antitrypsin deficiency is associated with severe emphysema. FEV1 is severely reduced. So obstructive disorders, you look for FEV1. restrictive disorder, you look for FVC. That is the thing. So in obstructive pattern of disorder, you have FEV1 reduced. So when FEV1 is reduced, FEV1 by FVC will be reduced. But in restrictive, both FEV1 will be and FVC will be reduced. But the factor of prognostication index or things like that is FVC. So for restrictive, it's FVC. For obstructive, it's FEV1. So in obstructive FEV1 by FVC, the ratio will be reduced. But in restrictive, since both are reduced, the ratio will be normal. Here they are asking about emphysema and the genotype. So emphysema, they have three alleles. One is M, other is so it is a polygenic inheritance. Okay, polygenic inheritance means more than two alleles are involved in its manifestations and its inheritance and its characterization. So M, S, and Z. M means normal. So if MM means it's perfectly normal. S means slightly reduced. So if MS is coming, there will be slightly reduced, but it will have adequate amount of alpha-1 antitrypsin to protect the lung. If it is Z, that means it's highly reduced. So if both are Z, that means it's severely reduced. The next in severity will be your SZ. Next in severity will be your SS. Next in severity will be your MZ, because M will produce normal amount. MM is the normal phenotype. Okay, so that is your ZZ pattern. That is the genetic pattern. Not phenotype, but genotype. Genotype is ZZ for severe alpha-1 antitrypsin deficiency. Next question. 35-year-old woman with chronic kidney disease, stage 5, was being considered for erythropoietin therapy. Her eGFR was 12, which is highly reduced, and she's stage 5 CKD. She's considered for erythropoietin therapy. On examination, BP was 140/90 and she had an AV fistula in situ for planned hemodialysis. HP is 95, MCV is 84. What is the most likely outcome of erythropoietin therapy? So they are asking what is the benefit of erythropoietin therapy? Options are improved BP control, improved exercise tolerance, increased ventricular hypertrophy, reduced likelihood of red cell aplasia, stabilization of renal function. So we look at the options one by one. Improved BP control. Actually, erythropoietin has around 30% risk for increase in BP. So there is no improvement in BP control. It can actually worsen the hypertension. Improved exercise tolerance. Yes, erythropoietin can help in managing the anemia and then improving their exercise tolerance. Increased ventricular hypertrophy? No, not much benefit. Reduced likelihood of red cell aplasia? No. Once you're giving erythropoietin, our body can produce antibodies against the erythropoietin, and there can be pure red cell aplasia, which is one of the side effects of erythropoietin therapy. So there is actually increased likelihood of red cell aplasia. So that option is wrong. Stabilization of renal function, not much. So the answer is improved exercise tolerance. Next question. 54-year-old woman who had undergone subtotal thyroidectomy for Graves' disease 20 years previously presented for a review of her recent blood test. She was well. Investigation showing serum cholesterol 6.8, HDL 1.1, TSH 16.2, serum free T4 13. So she had Graves and subtotal thyroidectomy, and she now has increase in cholesterol, and TSH is also high, which means she is having hypothyroidism. Free T4 is normal. What is the most appropriate initial treatment for her hyperlipidemia? So there is nothing asked about the thyroidism. Here the question is about hyperlipidemia. So here they are testing your knowledge whether you know there is association of hypothyroidism and cholesterol. Okay, so hypothyroidism can cause raised cholesterol, increase in cholesterol. So here the TSH is high, which means there is hypothyroidism, and cholesterol is high, which means there is hypercholesterolemia. So hypothyroidism is the underlying cause for her hypercholesterolemia. So the initial management should be thyroxine, not atorvastatin, no other options like ezetimibe or other things. The option is levothyroxine because here the hypothyroidism is the underlying cause for hypercholesterolemia. So they just tested your association, the knowledge whether you know the association between hypothyroidism and hypercholesterolemia. So the answer is levothyroxine. This question: a 27-year-old woman presented with the right-sided thyroid swelling and associated cervical lymphadenopathy. What is the most likely cause? So thyroid swelling and cervical lymphadenopathy. So they are asking which is the commonest thyroid swelling, okay, associated with also lymph node. So anaplastic can have a drastic prognosis, a very grave prognosis, bad cancer, but the prevalence is very low. So not that. Follicular adenoma, follicular carcinoma, when both these options are there, you have to understand that that is not going to be the answer, because you cannot differentiate adenoma and carcinoma clinically. Okay, the only way to do that is to have a biopsy and see. Even FNAC cannot identify and differentiate between adenoma and carcinoma, because the invasion of the basement membrane is the classification or the characterization of the carcinoma, which is setting it apart from adenoma. So there is no way to identify it clinically, and that is also not the commonest form of thyroid cancer. Hashimoto thyroiditis, that can present with features of hypothyroidism. It's an autoimmune phenomenon, not likely with cervical lymphadenopathy. So it is papillary carcinoma, which is the commonest form of thyroid cancer. So thyroid cancer, 75% to 80% is papillary. Follicular can happen especially in a long-standing thyroid, that is 15%. Medullary again is a very low fraction, 3%, but it's coming from parafollicular cell, usually associated with MEN2. That is another favorite question, MEN2. Even in the August exam which I had sat, they had asked MEN2, which of the thyroid cancer do you look for? It's medullary. Anaplastic, it has a very grave prognosis. It's the most aggressive form, but it represents only 1% of cases. Next question: a 77-year-old man presented with increasing pains around his lower back and lower limb girdle. He had recently presented symptoms of hesitancy and post-micturition dribbling. ESR is 28, calcium is 2.34, phosphate is 0.8, ALP is very high, 2985. Prostate specific antigen is 6. What is the most likely cause of this man's pain? We'll look at the options. So there is post-micturition dribbling. He had symptoms of hesitancy. He has increased pain in the lower back and lower limb girdle. He has raised ALP. Prostate specific antigen is not that much high, because in prostatic carcinoma and all, we can have a very high PSA level, but that's not the case. There is raised calcium, a lower the lower set of normal phosphate. So the options are insufficiency fracture of pelvis, osteomalacia, Paget's disease of Vaughan, polymyalgia rheumatica, prostatic carcinoma with metastasis. Prostatic carcinoma, I told you, PSA level is not that high. Paget's disease can have a raised ALP with normal calcium. Osteomalacia can have deficiency in calcium. Okay, so this option could be Paget's, because Paget's can present with your bone pain. Paget's can present with your raised higher set of normal of calcium, but usually ALP is the one which is more deranged in Paget's. You can have a very raised ALP. PSA in this case, it's not that high. So otherwise, if PSA would have been high with bone pain, with dribbling, there is symptoms of prostatism, you can think of prostate cancer with bony mets, because prostate cancer was one of the commonest malignancy which can present with bone metastasis. other being breast, lung, and things like that. So yeah, here it is ALP is raised, but PSA is slightly raised. So we'll stick with Paget's disease of Crohn. So that is the answer. So that's all for today. We had discussed 20 questions. We'll have a series of videos coming up, which is discussing the sample questions, which is given in the RCP website in detail, so that it'll be helpful for you uh, to brush up, to for your final touch up and revision. So all the best for your exams, and if you're sitting up for next exam, please feel free to subscribe and follow, because there are more videos coming up on this topic. Thank you so much.